Thank you so much, Dr. Fauci. That was a very comprehensive overview of the current state of affairs as it relates to COVID-19 and our future. And we have a few questions for you, Dr. Vonderheide.
Dr. Fauci, thank you so much. You're truly an inspiration, and we appreciate your service and all your colleagues at the NIH. The questions are pouring in, and so we hope to get to as many as we can. Everyone is asking about vaccines and when will a vaccine be ready, and we really appreciate your comments on that topic tonight. But scientifically, could you share your insight with regard to what have we learned immunologically about this virus and about our immune response to the virus that would inform how best to make a vaccine? Not all vaccines do all the same things. Antibodies, T cells, CD8, CD4. What have we learned that can direct us best?
Yeah, Bob, that's a great question. And we've learned a lot, but there are still some gaps that are going to wait actually for the proof of the pudding in the clinical observation. What we do know is that the durability of protection, both by antibodies that are measurable, as well as T cell responses that are measurable, but not as easy to do an antibody titer, that in the common cold coronaviruses, the durability of antibody protection and actual clinical protection is measured in several months to a year and slightly more. And that's the reason why we keep getting reinfected with the same 4 common cold coronaviruses year after year, year after year. Now, is that going to extend to the situation of a pandemic coronavirus, which really is more of a systemic infection in those who become clinically ill, as opposed to the common cold, which is generally reserved or restricted to the upper airway? We don't know the answer to that. We do know that people who got SARS had immunity that lasted for well over a year. The question that you're asking, I believe, that underlies that very interesting, simple question is, what are we going to expect from a vaccine? Is a vaccine going to induce protection that would last for a reasonable period of time, or are we going to be faced with the need to revaccinate, not because it's mutating, but because the durability of immunity is not the way we see with measles or polio or rubella? I don't know the answer to that, Bob. We're just going to have to
get a yearly vaccine, like the yearly flu shot type of thing.
Exactly, but for a different reason, because I don't think it's going to be mutating away from the vaccine protection. I think it's just going to be durability of immunity.
Okay, Charu.
What do you think are hoped for areas of progress for testing? What do we need to do to transform testing in the future? Should we be relying on saliva-based testing, or what do you think we should do?
Yeah, well, it's going to get me in trouble, but okay.
No, we're all friends here. We're all friends.
No, actually, there's testing for a couple of reasons, Charu. There's testing when you want to do the identification, isolation, and contact tracing. And then there's the surveillance testing for public health reasons. And a lot of the colleges are doing that. You test everybody before you let them in, and then you do surveillance testing a couple of times a week to see whether or not there is the insidious insertion of infection in the community. That's the kind of testing that we need for pure public health practices. Then there's another kind of testing that I would like to see. I would like to see a point of care, extremely cheap test that doesn't require relying on a supply of swabs, where you can just spit into a little tube, stick a piece of paper in, look at it and say, I'm infected or not. And if you are and you feel reasonably okay, stay home. If you're not, then you could go out. I think that would ease that extraordinary tension that people have about being restricted in doing anything because of the uncertainty. So the bottom line is, I think we really do, and we're doing it. I mean, when I say we, I mean the government, not me personally, is to really put a lot of effort into getting point of care tests that virtually everybody could have anytime they want it.
Yes. Dr. Fauci, some questions about treatment. So we're 7 months into this pandemic, and how would you assess our ability to treat those who get infected? It seems like there hasn't been a silver bullet, but yet we're doing better in terms of maybe hospitalization or the death rate. So what happened? Did we just learn so quickly, our frontline folks, or what's going on with that?
Yeah, there is a gap, Bob, in early treatments. In other words, right now, what we really want to do, we know that with remdesivir and with dexamethasone particularly, that you can really have a significant diminution in 28-day mortality. What we really need to focus on is the primary antivirals that you give to a person as soon as they have a symptom, or you give it to someone who's infected and you want to prophylact them against getting symptoms. We've got to keep the vulnerables out of the hospital. Mm-hmm. So if you look at monoclonal antibodies, I think that is going to be a giant step forward in the treatment of early disease. The only thing wrong with that is that it is difficult to scale up quantitatively how much antibody you can get for the hundreds of thousands of people that getting infected. But that's the direction that we're going, right?
And could we give those antibodies not necessarily by vein, but by injection?
Oh, I think we should be able to do it sub-Q. I mean, that's the end game here, to make it an outpatient procedure.
Charu?
Dr. Fauci, you spoke about this during your talk. Dr. Sharpless's article in Science about, predicting excess cumulative deaths from colorectal and breast tumors. This is largely an oncology audience tonight. What are your recommendations to us as oncologists to, as we normalize cancer care? What are the opportunities that we should not miss, and what should we be careful about?
Well, I'm not an oncologist, Charu, so I'm a little bit insecure giving recommendations. One of the reasons I stay in pretty good shape is I don't talk about things I don't know. But what I would think, just from a 40,000-foot look, you should try to get back to the normal type of screening that you've done as quickly as you possibly can. And if you can do that with the kind of testing that you asked for, get people to come in, test them when they're right out the door, get them in 10 minutes, and do the kind of screening. It's people not doing the simple things that you all have done in the oncology community so well for so many years. I would use testing to get back to where you want to be.
Yes, exactly. Yes, it's a major effort here, as it is.
That's very good advice. Paul?
I was being reminded in the questions that in addition to the racial and ethnic disparities emerging in COVID-19, we face that in cancer, major. And so now a patient with cancer and being infected with COVID, it's almost two disparities coming together. What can we do for these vulnerable populations to make a difference?
Yeah. Well, I get asked that question multiple times a day because, like just today, I spent 2 separate Zoom sessions with the Congressional Hispanic Caucus and a group of Hispanics in the business field, and they ask the same question. So there are 2 things I think you could do, Bob. There are the immediate things, and then there's the long range thing. The immediate things is to concentrate resources like testing capability and access to care to the best you possibly can for COVID, for individuals who generally are in a situation where they are going to get infected more often. When they do, they don't get to care very quickly. And when they do, they don't even know they're infected. And when you don't know you're infected, you spread it in your own community. And that's when you get the exponential explosion. So those are the things now. You try to concentrate resources that would have an impact, and that's mostly in the arena of testing. In the long range, what I always say, it sounds very idealistic, and maybe it is that maybe we can use this horrible experience we're going through to finally get us to try and do something for the decades and decades long problem of the social determinants of health that allow the minorities to be in the vulnerable position that they're in. It's not something we're going to cure overnight, but we need to make sure that we address that in the coming decades. I don't even say years, I say decades, because you don't reverse social determinants of health overnight. But that's what it keeps coming back to. We see the same thing with HIV.
Yes.
I mean, you have 13% of the population is African American, 45% of all the new infections are in African Americans. I mean,
Yes.
It just repeats itself all the time.
Maybe Charu, our last question from you.
So one of the questions that came in our chat is about healthcare workers traveling to red states and coming back to take care of patients such as ours that may be myelosuppressed and immunosuppressed. What is your advice? I mean, we are following recommendations.
Oops.
Charu froze.
Yeah. Sorry about that.
I think she wanted to know what your advice was for that.
Okay. If you can hear me, Charu, and everyone else, I think that gets back to testing. That you've got to, I think I know what your question was, Charu. You froze there for a second. Is that I think that one, obviously the proper PPEs, but I think testing, you should be able to test. You can't come back and quarantine yourself for X number of days every time you get on a plane to do a trip. That's impossible. That's out. So the proper use of PPE, because PPE goes both ways. It's either to protect yourself from acquisition, but also for transmission. But testing, you got to have sensitive and specific tests. When they come back, they do it in 15 minutes. They know, they go to the ward and they take care of the patients.
Excellent. Well, we have so many more questions, but we'll leave it there for now. We thank you so much for joining us, and it's a great talk. If you had mentioned Ben Franklin, we would have been even happier, but we're really, really honored and learned a lot. And thank you for joining us, Dr. Fauci.
Yeah, thank you, Bob. Thank you, Charu. And thank you, Larry. I appreciate it. Thank you for giving me the opportunity.